There we go. Okay. I guess we'll open up the discussion for questions from the floor. Do we have somebody to walk around with a mic? Okay, mic over here, mic over here. If you have questions, Odo, get up, walk. You can do it. We know you can do it. Don't talk from your no. Go walk to the microphone so we can hear you.
You didn't finish your exercise.
Yeah, you just pretend that I'm part of the treadmill.
Thank you. My comment is for Bob. You alluded to the gastric carcinoids and then later on to the PPIs. I think what we're seeing more and more as a differential is 3 and 5 year PPI-induced high gastrin levels, which can turn on the enterochromaffin-like cell and the enterochromaffin cell in the stomach, and you can see high CGA and high serotonin at times. But the CGA is the one that rises very fast. In our experience, it takes some 6 to 8 weeks to get the G-cell hyperplasia down, and that's a very difficult thing. I just was following up. The one thing Gene and I have feel that we have is that pancreastatin, which is a breakdown product of CGA, does not rise unless there's tumor in the liver. So the CGA will be elevated.
No. It doesn't rise
with the
with PPIs.
With the PPIs,
right.
yeah.
With PPIs, you get an elevated chromagranin, an elevated gastrin, and occasionally an elevated serotonin. But you never ever see, so far, knock on wood, the new syndrome, never see pancreastatin go up. So that's a way to differentiate whether your enterochromaffin hyperplasia is indeed a gastric carcinoid. So again, gastric hyperplasia with PPI, chronic PPI use, increased gastrin, increased chromagranin, normal pancreastatin. That may be the key thing. Over there. Yes, Dr. Second.
Should I comment on that? Or?
Please. You just hop right in here.
Okay. I think that, there's a very important observation you've made. I just would put in one caveat that I think is important, though, that you consider. That is your pancreastatin assay. One of the problems that happened with chromagranin is there was a proliferation of assays, relatively uncharacterized, that maybe certainly were not all the same. So one of the things I'm going to make with this thing is that if this is the very solid of observation, very important, there now will be a proliferation of pancreastatin assays that I hope show the same thing that yours do, but they very well may not, because these things are not well standardized, and that is going to lead to the whole other mess. And one of the things that slowed the use of chromagranin in this country.
Yeah, absolutely. I cannot agree with Dr. Jensen more that chromagranin assays, if you look at the Europeans, they've now done the right thing. They've done the split tube testing, and they can now tell you whether a chromagranin A from company X is the same as a chromagranin A from company Y. For Dr. Odorisio, who set up the pancreastatin assay at University Reference Labs at Ohio State, and the folks at ISI who have a pancreastatin assay, the only two in America, they are absolutely parallel, but they're five-fold different. And Tom was able to show that that's because the URL antibody sees part of chromagranin, and there's some cross-reactivity. But you're exactly right. I cannot tell you if there's one thing I think NANETS can do as a group is standardize laboratory testing across the United States. It's exactly what the Europeans have done, and it's exactly what we're going to have to do. Bill.
Okay, let's keep on the guideline. Question for Bob also. I was wondering whether it's still useful to perform angiography with the gradient, which are cumbersome at the area of a very specific and sensitive results of EUS, for instance. So would you really, in guidelines, recommend to perform angiography with the gradient determinations in difficult cases?
Well, it's probably for that reason I didn't put that flow diagram in the guidelines. But in answer to that, no. But I think there is a role for it that we did mention, and I put this up for your, in fact, you had some of this data. I've seen one of your slides. In a patient where everything is negative, where you consider the fact that he has a single liver lesion, if you can find somebody to do an angiogram, you should do it. Because that is big surgery, okay, and you will be surprised. Sometimes you will see some miliary things that will change your approach. So in that particular case, the risk from an angiogram far outweighs the possible benefit, and I would put that one caveat in. The other role for angiogram continues to be in the case of insulinomas not localized, and with the combination with the calcium stimulation. There now is a vast abundance of this Dotman test on the usefulness in that small number of tumors that are difficult to find. And also, Tom Odorizio has a paper that you probably could do that with a small Vipome or something else. The infusion of the calcium causes the VIP. So in the tumor where you can't find anything, there may be a role for this.
Could we just add one more thing to that, Bob? I think that's terrific, because in our institution, when we have people with multiple endocrine neoplasia, we like to know not the tumor.
Speak into the microphone, Arthur. Thank you.
We like to know not the presence of all the tumors, but we like to know the one that is actually secreting, because each one may secrete a different substance. So still in those cases, for example, in gastrinoma, we like to know which one of those tumors so that we can go for it. So we still do sampling in those particular patients.
Dr. Yao, you have a question, or are you just holding the microphone? Okay. Dr. Baum.
Just a small comment to the use of positron emission tomography, PET. I suggest that you indicate which type of PET you really mean. Yeah. Because when you're speaking about PET, probably you mean FDG, fluorodeoxyglucose PET, but meanwhile there are at least 5 different types of PET we are using in neuroendocrine tumors, like FDOBA PET, gallium-68 receptor, PET-CT, and so on. So I suggest, especially in guidelines, you should say FDG or DOPA or, somatostatin or whatsoever.
Okay, I think we had a little bit of a problem, as usual, on this particular aspect. We're a log unit behind you guys, and here there are no general availability or approval of any PET imaging in these tumors. And so, except perhaps the use of FDG in undifferentiated tumors where it's used. So I think that I don't even remember we have a sentence in there about that, because there isn't any general availability of that. I think we might have mentioned it, but that was we don't have much on that.
Dr. Rinke, you had a comment?
Yeah,
Bill.
This question is for Dr. Jensen, perhaps for Dr. Koki, maybe in the room as well. I think we spent a lot of time talking about the endocrinology, physiology of these pancreatic neuroendocrine tumors. But what do we do with people with unresectable diffuse metastatic disease? This is an area where there perhaps are effective systemic treatment. What is the recommendation there?
Well, I could give it, but where's Matt? You're hiding, Matt. Can you comment on that, Matt? Because you actually wrote that part, and I agreed with it, but I don't know that I remember it all. Okay.
Bob, you're too honest.
So I think there are really a wide variety of treatment options for patients with metastatic disease. At this point, there is no real, I think, accepted standard for every single patient. But I would say that the options would include for patients with hepatic predominant disease, liver-directed therapy,
Are these
embolization.
PNETs, carcinoids, both? You put them all together. So we know what we're talking about.
So I would say for pancreatic neuroendocrine tumors.
Pancreatic. So PNETs, that's where we're going to go first.
Yeah. And so in addition to hepatic-directed therapies like surgery or embolization, systemic treatments would include what we call targeted therapies. There's some interesting preliminary data with sunitinib that I think we're going to hear about. I think chemotherapy, in contrast to carcinoids, does play a role in pancreatic neuroendocrine tumors, whether that's streptozocin-based therapy or temozolomide-based therapy. And intriguing data in carcinoid regarding somatostatin analogs that potentially could be extrapolated to pancreatic neuroendocrine tumors, though we don't know that for sure yet. So really many options in that context.
And that doesn't even begin to talk about, sending people to Europe for PRRT, et cetera. So, I mean, there are some exciting new things coming down. Dr. Rinke next.
Yes.
Then Dr. Shaw, I believe, needs a microphone. Bill, yeah. Dr. Rinke?
Yes, comment and question for Dr. Phan. I felt very much uncomfortable looking at the fact that you want to change the nomenclature for this type of tumors. We always admire the fact that our smart lung pathologist long ago proposed something which is working, still is working. So if you want to put this in a guideline, be careful, because many people would not simply follow the thing, and that's one thing. And the other thing I was surprised about is the fact that you mentioned that in lung, most of the cases are not localized. So I was confused because you were talking neck, which to me is poorly differentiated, then everything was in. So it's a little bit confusing. Most of the cases in thoracic surgery centers, cancer centers, you will see are basically very much localized, well differentiated. Let's call them again carcinoids, while the others are always high stage. So these things should be taken with extreme care, because people who's not confident with the field is going to get the wrong message. That's my major problem. We entered this problem, let's say, a few years ago when we decided to go for guidelines. So these two things are quite sensitive. I warn you to be extremely careful touching this sort of aspects.
I think the recurring theme that I've heard time and time again from my colleagues who are average, hard-working guys out in the community, who are somewhat knowledgeable, but not intimately knowledgeable like the people in this room, is that they're not going to read 225 pages to find out what happens. They want the cliff notes, as we say here in America. They want a one-page summary of what they should do, X, Y, or Z, or where to go look, at least, where X, Y, or Z. Dr. Shaw.
Wait, that question was for Dr. Phan. Could we give her an opportunity?
Yes. Was it a question? That was, I guess, the main question.
I think just to defend myself, the guideline is a proposal of the guideline as far as to unify the classification. So I guess the answer to that is what's in the name. I have, when I present the data, it was based from the proposal that came from pathology in development of a unified guideline as far as to call all neuroendocrine tumors or neuroendocrine carcinoma a different grade. I have no doubt that I need further validation. Everybody has to be agreed upon that. But I have problems with that because I don't know if everybody will be able to agree upon that or not. So how to proceed forward, I think it's going to be a heated debate sometime in this conference. There's going to be a whole session on pathology and nomenclature and classification. I can only say that, to defend myself, I only work based on what people gave me. Right, no, I understand. No, I totally appreciate that, because that was the part why I went through it very quickly, the part about pathology, because I was hoping nobody noticed, but I'm sorry.
Yeah, right. If you remember the last NANETS meeting, everybody was very cordial until it came to the pathologist, and then I saw somebody in the back of the room walking around with an AK-47, and he said, pathologists, big sniper thing. Anyhow. Yeah, Dr. Shaw.
So I have a couple of questions for Dr. Phan and the team related to lung carcinoid guidelines. So do you guys address the tumorlets that are seen in lungs? Because there is not much in the literature, and I think that, when the cases do come, it would be good for experts to have some suggestions. And then second question, or rather comment, is about, you mentioned cytotoxic chemotherapy as an option, and in parentheses there was only temozolomide. I was wondering if you have put etoposide platinum-based chemotherapy for moderately differentiated or atypical carcinoid.
Again, I think I only list what's available as far as data. Temozolomide, there's data for that. Etoposide platinum is for poorly differentiated and probably even atypical carcinoid as well. But then that's where the nomenclature comes about. What is atypical and what is poorly differentiated? So the role of chemotherapy does play in thoracic neuroendocrine tumors. What it is, as far as whether it's just temozolomide-based or platinum-based or even etoposide-based, I don't think anybody can say definitely one option versus the other, because it's depend on the grade of the tumor as well, because I've certainly treated a lot of typical or atypical neuroendocrine of the lung and get no response with the platinum-based therapy.
Next will be Dr. Pommier's question.
Just a comment about the treatment of the symptomatic bronchial carcinoids producing ACTH. Aminoglutathione is unfortunately no longer available. Novartis stopped producing it. I've got one patient who bought all their raw material, and she's having it compounded in an effort to stave me off from removing her adrenal glands as long as possible, but it's unfortunately not available anymore.
Sue Odorisio.
I heard both Dr. Vinik and Dr. Jensen talk about how long it is to make the diagnosis. And I certainly think our guidelines need to be helping people make this diagnosis early. So maybe some guidelines about for the gastric carcinoma in the 5 years before it gets diagnosed, what are those initial symptoms, and at what time do you start to do the workup?
One of the things I would plead for is a comment somewhere about the long-term use of PPIs for years and years and years. That, you know, if you look at the FDA's guidelines and even on the over-the-counter stuff, it says use it for 12 weeks. And yet, in my institution, once you're on a PPI, you never come off. It's like herpes. It's the gift that keeps on giving.
Yeah, that's a very difficult question, Sue, because, you know, we keep listing the types of clinical situations that should lead to a suspicion, for example, of gastrinoma. And, for example, with insulinoma, you know, it's well known. If a guy drives through a barn, maybe there's something wrong with him. But the problem is that I don't know how to get those out to people, because what you realize when you talk to practicing physicians is that these guidelines are, these tips, let's say, are so general that they're often in a sea of a much more common disease. And so until they become flagrant, they're difficult, and especially with the prices of radioimmunoassays and the restrictions on that. So I'd like to, I'm not sure, besides education and trying to put it out in guidelines like that, that's why these shouldn't just be only guidelines, because you got, and I agree with you, in there at least we've tried to emphasize what should lead to the suspicion of the disease. I'd be interested to hear Irv's point on how we could move this a step further, but what I know is that in the big medicine articles we did on gastrinomas, it's not changed one bit in more than 30 years. Okay, we're no better than Zollinger was, and so I'm not sure that we're
maybe that, Bob, does that have something to do with the fact that once you're on a PPI and your gastrin is 600 or 700 or 800, that suddenly, if you try to come off of a PPI, you have effect created Zollinger-Ellison syndrome for a short period of time, that they then flare, and the doc goes, holy shit, now I'm really in trouble. I got to put him back on a PPI.
Well, I'll just say, yeah, that's part of it, but what you don't realize is the exact same thing is true in most series of insulinomas. So you could say, well, maybe they're historical. So this problem is not peculiar to ZE. What he says is exactly true. I'd like to hear Irv comment on this.
Yeah. Let me also comment on this, Sue. I think what we've been doing for years, and I showed that the median time for the onset of symptoms, say irritable bowel, abdominal pain, colicky type pain, for the carcinoid is 9.2 years, 5 years for ZE. If you go back and look at the pheochromocytoma literature, it's even longer than that people have symptoms that may or may not be related. So what haven't we done? What we haven't done is to take those people and done a markers to see whether or not we're predicting very well. No study has been done like that. We need to actually take that cadre of people, and you see how large they are. And that's why I showed you the symptom complex across countries for irritable bowel, for example. There's a large cadre of people, and until we've actually looked at markers across the board, maybe done the proteomics, maybe done the genomics, come up with a perfect marker to say, yes, when you have that symptom complex. Otherwise, am I going to really measure chromagranin, say, in every irritable bowel? And how often am I going to be doing it? And how long am I going to be following that patient until they have the syndrome? I don't think we have the answer to that at this point.
Yes.
Thanks. Dave Metz from Philly. I wanted to just comment on that because as a practicing gastroenterologist, let me tell you that there are a whole lot more patients with reflux disease who depend on their proton pump inhibitors for surviving every day than there are neuroendocrine tumors. But there are a number of issues that are coming up as a consequence. So Bob has shown and Philippe has shown that the diagnosis of ZE is delayed now that the PPIs are around. As was mentioned by yourself, there certainly is a dependency that's created by putting people on PPI, activating the feedback loop, making them hypergastremic. But the bottom line is there are very, very few of those zebras for all the horses running around there. And I think a couple of guidelines from a gastroenterology point of view that need to be put in place is the reverse, and that is some guidelines for using proton pump inhibitors. Lowest effective maintenance dose, which is something the Europeans have taught us and I think is very important now. It does cause chromagranin A to go up, but if you use a dose and you don't make him too hypergastronemic, you're going to make him a lot better. One of the big issues that has never been assessed in terms of gastrin that maybe this group can address, and maybe Bob can comment. We always measure fasting serum gastrin in the morning before breakfast, which probably has absolutely no clinical relevance whatsoever. It's the area under the curve after meal stimulation, and nobody ever measures that. We all talk about how long it takes for the effect to go away, but in essence, nobody knows how long it takes for the effect to go away. The only paper I know is Bob's that we did back in '93 when we looked at cure of ZE, and it's 3 to 6 months for your acids to come back to normal.
And I can tell you the PPIs just parenthetically, I think, are the same way.
So we don't have those.
We need to do that study. That's a great study that would.
So that's just a couple of comments.
We're running out of time. Is there any other burning question? We're going to be taking a break for the next 20 minutes. We'll see you back in 20 minutes. Thank you very much.
Thank you.